comprehensive and is definitely condensed. I'm happy to talk to anybody in more detail after the fact. And I can make myself or my email available to anybody who wants to email me. It's totally fine. So congenital heart disease, just kind of starting off with definition. So congenital really at its simplest level means that you're born with a heart condition. And I think that we in congenital heart disease really focus on things that are structural issues with the heart. There are congenital issues with electrical channels that are, congenital heart block in terms of conduction through the conduction system. Really, a lot of what I do is take care of patients who are born with issues with chambers of the heart, which means that there are either holes between the chambers, that the valves are somehow malformed and cause issues, or even in sort of more peripheral structures, the aorta, bigger blood vessels, some of the veins. Some of those are narrowed, some of those are just abnormal inherently. And so we follow patients who have those structural issues. And we'll get into a little bit like what comes with that. But one of the important concepts that's really the focus of the next couple slides is that while the number of people who are born with this is not a huge proportion, it actually does represent about 1% of the population is the number that's typically thrown around. And as we've gotten better at taking care of these patients, we have a growing number of adults with these types of conditions. So if you can imagine, like you have a stable number of kids who are born with these conditions, and we get better at taking care of them, the group that make it through to adulthood is just going to grow and grow and grow. And there is variability in terms of how severe that disease is. Some is very mild and doesn't get noticed until like they're well into adulthood. I've met 80-year-olds who get like diagnosed with things for the first time. And some, like you're born and you're off to the races and you need to get surgery right away to save your life. So there's a ton of complexity, a ton of variation, and we'll go through some of it. So infrastructural issues, probably the reason why I haven't sort of met a lot of you and why you haven't met a lot of ACHD fellows is that like there are currently 400 people who are trained to take care of these patients. There's about 2.4 million people. And so like the ratio there, if you think about the entirety of the United States, 400 doctors is not a lot of doctors. So we're a center that's very fortunate. We actually have 4 attendings on service, and in addition to 2 nurse practitioners, some of the nursing staff I saw on the call, thank you very much for coming in and providing support, and our administration. So we're very fortunate. And a lot of that has to do with investment in this field that's come from Children's Hospital of Philadelphia and the institution on this side. And this is essentially explaining that concept I was explaining before. This is data that's out of Toronto, which says, yep, kids are going to be born with congenital heart disease and those problems, and they go through children's hospitals, and we maybe see them in different sort of advertisements for funding for children's hospitals. But as we have better treatments for these people, more of them are going to make it to adulthood, and we're going to see more of them in our adult ICUs. And so we have to be more and more ready to understand what's going on, and also to understand systematically like who I am and how I can help you. And this is just a map showing sort of the distribution across the United States. There are some places that have no congenital heart disease providers. There are some that have no centers at all. Even like there are places like Wyoming and Montana. We have people who are housed in Colorado or in Washington. They go out to those states because there's nobody there. So it's a huge need for this growing group of people. That's a couple million people now. So, and this is just kind of maybe to play my violin a little bit, but to show the duration of training is that I'm currently 9 years out of med school and 13 years out of college. But one of the great things I think about nursing is that in flexibility in your career, you can really have a dedicated focus that you can not necessarily have to devote 13 years to. And so if there's any interest in learning more about this field, even just if it's sort of a peripheral interest or anything along those lines, some of our nurses are actually on the call, and Rob Carvel is our sort of veteran nurse on the ground level, who really is approachable and wonderful, and it's definitely more than happy to talk to you about sort of how things go in ACHD care. So I wanted to talk about some practical things. I'm more than happy to answer questions as they come up. Maybe some differences between what we typically see in adult cardiology. I am an adult cardiologist. I'm not a pediatric cardiologist. So I have been in the unit for adult types of issues that are separate from this, and kind of explain why maybe we approach certain things a little bit differently, or why sort of a little bit about how our brains work, maybe is the simplest way to say it. And then at the bedside, there's just a few high points I wanted to cover. If there are any specifics, I'm more than happy to cover those, but I thought these were kind of low-hanging fruit for this type of talk. So the first idea in terms of heart stress that we typically see in the adult cardiology setting. So I think that, I don't want to belittle the idea of adult cardiology. I recognize it's become more complex. I actually do research in cardiac amyloidosis, heart failure, and those types of things separate from what I typically do in my day-to-day life. But a lot of what I see in the adult cardiology space is either coronary artery disease or calcific valvular disease, endocarditis, valvular issues. You've seen them, they have variable types of history. But as you kind of move through things, you kind of develop traditional senses of what is the stress that's going on in the heart. Well, if there's an obstructive valvular lesion, then the heart really has to squeeze and potentially hypertrophy to move things through. And it's very easy to develop, or it's not easy to develop protocols, but it's more straightforward potentially to develop protocols when you have a number of patients move through sort of one type of problem. So STEMI is a great example. You can really be systematic about activating based on an EKG, going to the cath lab, having post-procedural care, having nursing protocols to look for different types of arrhythmias in the post-procedural setting. For aortic stenosis, we have post-TAVR. There's definitely changes that happen in that context as well. And really the stresses that we see in congenital heart disease are somewhat all over the place. And I think, the way that I say this is like, the heart is as different in my patients between them as their fingerprints are. There's a huge amount of individuality, I would argue, in sort of normal anatomic hearts, but especially in congenital heart disease. And so a lot of the stresses that I see are, there's a hole between the chambers, and that means that your LV is actually pumping to not just out your aorta, but also into your right ventricle and out your pulmonary artery. And there are certain types of sort of remodeling and stresses that we see as a consequence of those types of things. The picture in the middle is actually not sort of an uncommon thing that we see, where both the aorta and the pulmonary artery come off of the right ventricle. And so in that setting, we have to think about, okay, well, we have a left ventricle. Where is it pumping to? It has to go across this hole and out both. And then what do you do in that type of circumstance? And then the last one is just sort of one of the examples of something that we see in the periphery. It's coarctation of the aorta. So you can imagine this isn't aortic stenosis in the truest sense, but it still is an interesting situation where the left ventricle is pumping out and facing a big narrowing in terms, before it's able to pump blood down to the legs. And so we see, that causes a lot of stress in the heart and also in different parts of the body, because it depends on, is the organ that we're seeing getting perfused before or after the coarctation. So there are a lot of considerations there. Then the second piece is the surgeries are extremely complex. And I believe you probably have seen a lot of the terminologies in the patients that have come through. The person in 33, the anatomy is fairly complex, and actually sort of her surgical history is somewhat interesting in 833. And that she had something toward, or the second picture from the left, that was attempted in her with the idea that we were going to like reroute some of her blood flow to her pulmonary arteries. And it's, there's, that comes with certain stresses. Hers actually went down, and so that is no longer open. Now it's discovered at a cardiac catheterization. But essentially, the way that we correct these things is by putting prosthetic material in, or rerouting flow, or saying we're going to sacrifice, any flow that comes from the left ventricle. Let's just give it up and let's make the right ventricle pump to everything. There's a lot of complexity to these surgeries, and the consequences of those are, it's one of the more interesting aspects of the job, because if you think about the patients who are reaching adulthood now, you're seeing the consequences of the surgeries they had 20 years ago. And so we were always kind of playing catch up in the idea that we're trying to have an understanding of, all right, so, this got them through the childhood, this got them through sort of the intuitive idea, but what is going to hold up, in the long term. Like, we want these patients not just to make it to 20, but we want them to make it to 100. And so how long do these surgeries last? When do we need to think about other surgeries or other measures to push them further? Because these surgeries, while they correct things in the short term, they also are not free of stress. The other thing that I think is important to bring up is the level of acuity. I brought up STEMI as an example before. STEMI, I think many of us realize it's a fairly acute phenomenon. It may represent somebody who is, like cheeseburgers a lot in their life, and they maybe have not been the healthiest, but all of a sudden, bam, an artery closes, they have chest pain, we have to go because the heart is acutely weak, and we have to figure out what to do. We have to revascularize, otherwise the heart sort of function will deteriorate. There may be tears in the heart muscle, which is something that we're seeing here on the right with the hemopericardium with the free wall rupture. So a lot of things that we see in the adult ICU, not everything, but a lot of what we see is an acute change. Something that I see a lot is a condition that started off when a person was born or is diagnosed when they're a child. And they have potentially lived with a fundamentally disordered physiology their whole lives. And so I don't just think about like, oh man, this is the acute issue, we have to change this right now. I have to say like, okay, well, this person's been alive for a long time now, and they've done that somehow. I think about how they lived, and I also think about like the measures by which I can realistically determine whether or not things are sustainable. And so to go back to the example of the person who's in 33, her oxygen saturation is in the 70s. Probably been in the 70s her whole life. She has we'll talk a little bit more about the specifics of that anatomy. So that's not an acute change. It's the way that she's existed. Her body has figured out ways to make that durable. And so I have to think about different things in order to sort of get an assessment of when to make changes, when we're really struggling, and how to move things along in a positive direction. So, I think that it's an important thing to reflect on, because a lot of our patients, they come into the hospital and there's this feeling of, well, this person's in heart failure and we need to like go X, Y, Z and follow a protocol and let's get their oxygen saturation up to 100%. And a lot of the time these patients have been living and they'll accommodate, and they actually have a lot of insight into their own conditions to know, like, this is what, a lot of, physicians, will do because they don't recognize the pathology. And it leads to, discussions that I have with them, and we kind of try and make sure, and discussions with me, but with a lot of services, to try and create reasonable goals and understanding where we're at, because this person isn't just sick today. This may be the latest step in their whole lifelong journey. And that brings us to a third concept, which is really a reflection of the second, in that they have sort of adaptive mechanisms that have brought them that far. I don't know how much you guys remember ideas surrounding glycolysis and gluconeogenesis and lactate generation, all that stuff. I did not bring you here, hopefully, to bore you, but their bodies have to have fundamentally different physiologies in a lot of ways to use energy and to deal with certain stresses. Like a lot of our patients, they have like chronic liver hypertension, is a way to say it. So their liver is always under stress, and because it's been under stress for years and years and years, there are just changes in the way that they process all of the metabolites that they do. So, I bring that up just to say, like, I'm not just saying this willy-nilly. This is the idea that like they have lived with this forever. Their body has adapted. There are biochemical reasons why they exist the way they do, and it's not the way that we all do. And really, I think that's probably the most fascinating science to come, is to show adaptive mechanisms for how people can exist in that situation. And maybe we can apply it to adulthood. A lot of the time I go the other way, try and say I want to apply things from the adult world into congenital heart disease. So what does all this mean? Essentially, it means it's very important to understand the differences that we see in ACHD patients. I am always here to help you. And our team is too. And a lot of what we do is try and sort of clear up some of the fundamental differences that they have and try and set things up so that the team can do the best they can with diuresis or with oxygenation, or, so that we can kind of work together as a team to find the best way forward for the patient. And it's also important to understand that a lot of what I've talked about, their fundamental differences, people have arrhythmias at younger ages, people have endocarditis, people who have sort of low oxygen levels, they inherently have increased risks because of differences in their metabolisms. And then coronary issues, a lot of the coronaries don't come off in the right places, not in the traditional spots. It's an interesting world, actually. But, more of what I think about is whether or not we're going to, transect a coronary during a surgery, or whether there's an anomalous coronary that comes from the wrong place that's causing an issue. There are all different types of things that we think about in that sense. So there are differences, and we're also here to help. So bedside practical issues, and I promise not to take this too long. One thing that I think is probably an easy way to get some ground level exposure, and also like one of the coolest stories I think in the history of medicine, is to watch this movie that was made by HBO. I think it's like 15, 20 years ago. It's called Something the Lord Made. It's got Alan Rickman, I think one of his best movies. I know a lot of Harry Potter fans probably out there, and Mos Def. And it's a story about a surgeon named Dr. Blaylock, who is Alan Rickman, and his essentially associate or assistant, his name's Vivian Thomas. They met in Tennessee, but they moved to Hopkins, and heart surgery was not a big thing back then. Like in the, I think it was the 50s, might have been the 40s. And so Helen Tausig, who I don't know that actress's name, but she's there in the bottom, was a pediatric cardiologist. She had all these babies who were cyanotic and were not aging. And she was trying to think like, well, what can I do? And they all got together. Actually, Vivian Thomas, like probably, I don't know, I hope he's more recognized now, but like made fundamental changes to our understanding of congenital heart disease and how to treat these patients. And I'll talk through the surgeries that they did, but it's a great movie. So anybody who wants to get hooked and has HBO. And HBO in general, I would recommend for other reasons too. So, it brings me to this first sort of bedside concept where you'll hear us talk a lot about, you can only measure blood pressure in this arm or that arm or, whatever. And, blood pressure, I think everybody here realizes you have the Korotkoff sounds, and that's what you do for non-invasive pressure. You can have art lines, whatever. But a lot of what we do on a regular basis in adult ICU relies on fairly traditional vascular anatomy. So you have two subclavians. There's no sort of big obstruction that's, between that and the femorals. So like a lot of what we're seeing on the left is what we expect, right? So this surgery actually that Vivian Thomas and Dr. Blaylock and Dr. Tausig invented is called the BTT shunt. It's called the Blaylock-Tausig shunt, but I actually think one of the important things is they recognized Vivian Thomas. They made it BTT instead of BT. And essentially what they did was they rerouted the subclavian artery to the pulmonary artery. The issue in tetralogy of Fallot is that essentially you have a smaller pulmonary artery, you don't get as much blood flow to your lungs. They were like, well, how do we get more blood flow to the lungs? And so they rerouted the subclavian artery to do this. Now, like part of the issue is like, let's say that I put an art line in the artery that's like rerouted, it's not going to be representative of anything, right? Like it's going to be representative of just like whatever little bitty vessels were able to find its way over after we did this surgery. So it doesn't make sense to measure blood pressure in that arm because that's not the patient's real blood pressure. It's just going to make us panic and we'll start going up on pressors, and we shouldn't do that because then their blood pressure really is going up and we don't know why. And so that's part of the reason for that type of advice. Now, this is the traditional Blaylock-Tausig shunt. This is a modified Blaylock-Tausig-Thomas shunt. And essentially, they've made it better such that they have essentially a conduit through which, blood, you essentially hook it up to the subclavian, hook it up to the PA, and blood flows through that instead. So that means that the blood pressure that you would measure is more reasonable as a representation of what the systemic blood pressure would be. Although, some might argue that it's just easier to just go on the other side, and that makes sense. Although we do have patients who also have bilateral BT shunts, and in that case, you definitely should be calling a congenital consult. This is called the modified shunt. Then the other piece with coarctation of the aorta, I brought it up a little bit before, is you can imagine this scenario, the heart's pumping blood, it goes through the ascending to the arch and has blood vessels that are branching off. So that's fine. You know, you get blood flow up to your head. And actually, one of the recommendations that we have in these patients is to look for intracranial aneurysms, because they can have higher blood pressures in their brain. Because the cutoff, I mean, means that the pressure is going to all go up that way. And then this is also why we see these sort of collaterals that develop. A lot of the intercostals kind of grow, and then they kind of come and reperfuse the descending aorta. It depends on how narrow things are. Sometimes it's just narrow enough that blood can get through. But you can imagine, like, if you're not getting femoral pulses, and like, you know, you have to think about, like, oh, does this person have a history of coarctation of the aorta if they have like these great pulses up here? Have they been repaired? There's a bunch of different repairs beyond the scope of this. But that's another reason, like, not that I think anybody would do this, but if people are feeling a fem and they're like, oh man, this guy's pulseless, you know, like, stop, think a little bit, call us, look for the idea of why that might be the case. And so, yeah, pulses, that's sort of the big piece here. Oxygen saturation, so that's a big one, especially for this lady who's in 33. And so a lot of the time our patients float a little bit lower, which creates a lot of anxiety for a lot of people overnight, potentially, especially. And so, like, let's just kind of go through a thought exercise. We have a heart. This is a normal heart, so no tricks. And so you have venous return, it goes back to the right side of the heart, gets pumped out to the PA, goes back to the left ventricle, goes out to the aorta. So in this scenario, I give this person oxygen. All of their blood is going out the PA to the lungs. It's going to pick up oxygen, come back. I have my nice, perfect saturations that we all love, that we're happy discharging people with, happy ending. So, you know, in my world, there are a lot of people who have holes in their heart. And as a consequence of that, not all blood goes to the lungs. And so you can imagine a world where, like, you know, we're trying to go up and up and up and up on oxygen, and nothing's happening. Like, we cannot bring the oxygen saturation up. And part of the reason why is because not all of the blood is going to the lungs to pick up the oxygen anyway. So you can give them as much oxygen as you want. You should think about that, because oxygen can be toxic to the lungs at high doses for prolonged periods. And just fundamentally, there's no way that the blood is going to pick up oxygen. You're never going to get 100. So that's another thing that we weigh on routinely, is whether or not, you know, what the baseline saturations are, whether there's development of collaterals that mean that the blood is not seeing the lungs. Really, it's like, is the blood seeing the lungs, yes or no? And in situations where no, then a lot of the time we have patients who have cyanosis or like have chronically low sats. Sorry, I'm a little bit over. Is it okay? Okay. It's almost done, I promise. The picture on the right is Our Lady in 83, or in 33 rather, 833. And so she has what's called tetralogy of Fallot with pulmonary atresia and major aortic pulmonary collaterals, TET-PA MAPCAs for short. And part of the reason why her saturations are so low is because, as you can see, she only really has one outflow, an aorta, and she has a big VSD. So the way that her lungs get blood are actually little branches off of the aorta. And so you can imagine, if you're shooting all the blood out your aorta, only a portion is really going to go out to the lungs, pick up oxygen, come back to the heart, et cetera, et cetera. So this person, no matter how, like, you know, there are certain things, the idea of oxygenation and maintaining certain levels of oxygen carrying capacity that's important for her physiology. But you can't get focused too much so on a specific number or getting up to like where we would want to be normally, because she has a physiology that has tolerated this her whole life. So the VSD and the like way that her lungs get blood is not something that we can fix. And so we are willing to tolerate lower saturations. And so, like, I get it already, they're desaturated, blah, 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 congenital guys beating the horse. So what can you do? You can call a cardiology fellow. We talk to a lot of them and they know a lot of this. You can call us and we're more than happy to discuss things. But a lot of what we do is look at the history. What was their saturation in clinic? That's like a reasonable baseline that we discuss and we kind of work within. And then we also know some things about the anatomy that are less intuitive. Um, but I really think a lot of the cases that we see in terms of, oh man, what's the saturation? What's their baseline? You know, you can look at a clinic note and somebody who has seen us, we put saturations in every note that we put out there in our clinic. And I think that could potentially be a big tool for you guys. All right, so IV care. So there's a few major concepts. We talked about sort of this hole in the heart and whether or not sort of blood is moving, moving across it into the systemic circulation. So you are vulnerable to paradoxical embolism. And so a lot of weight in our notes is put toward filters to avoid air emboli, cleanliness to avoid infection, because these patients may have low saturations. Like I said, there's vulnerability to infection, and some of the patients have brain abscesses and things like that that potentially could be prevented with good cleanliness and hygiene. Then central access is tough because let's say, I'm not saying anything about any general cardiology fellows, they're very good procedurally. Let's say that they have a very small patient, they put in a long line and it goes through the tricuspid valve and we're actually in like the the LV or something like that. It's difficult because lines, while they are sterile when we put them in, they are in the patient and in their environment, and little clots form, little bits of fibrin, they're nidus for thrombosis, they're nidus for infection, and that stuff can flick across with more consequence than just going to the lungs. So that's one big thing. Vulnerability to endocarditis, I kind of skipped ahead of myself. There's the brain abscess, there's the endocarditis. And then I talked a little bit about blind thrombosis. But the other thing that I would say is that this is a patient, a lot of our patients, they have this word Fontan attached to them. Fontan is actually the name of a surgeon. This is the kind of end product of all of the sort of surgical sequences that we see. And you can see that an easy way to maybe understand this is that there's no RV. There's just no sort of subpulmonic pumping chamber at all. There is physically a right ventricle, but there is no heart chamber that is pumping blood to the lungs. So that means that all of the blood that is going to the lungs is actually just moving passively, like down a stream.
As a result of the Fontan procedure?
Yeah, as a result of the surgery. So like essentially what they do is they hook up your SVC and your IVC to your pulmonary artery, and it relies on pressure gradients to move things through. So it is literally just like a stream. There's no pump that we typically see, and like the lungs become abnormal as a consequence of that potentially. But like, let's say we put a line in there and like we just kind of, say we're gonna put something in the stream. Well, that stream, I don't know, maybe taking this analogy too far, there's a rock. You put the rock in the stream, stuff's gonna grow on it, all this stuff. And there's no sort of ability for us to really do too much to protect the lungs from what could be sort of a growing clot or a growing stress infection. That's why, while it's annoying, and I know that, I love central access and I can have it too. In some of our patients, it's a better idea to not have it.
Because there's no pressure to like wash the catheter.
There's no pressure at all. It's much more static. So like we don't have like the RV kind of pumping away and helping things move along at all. And the RV actually, when it fills, it generates negative pressure to move things along. You don't have that either. So and like this is another reason we don't get into this, but like we also have patients who have difficulty with intubation with this type of anatomy, because if you imagine your intubation is you're putting pressure into the chest, right? And so essentially that's the same thing as sort of pushing down on that sort of cross there in the upper left-hand corner, sort of squishing it and creating sort of a barrier to have this stream. It's like damming the stream a little. And so that can be disastrous because essentially you're depriving the heart of a bunch of its venous return and you'll potentially cause spiraling. That's some of the way that we think about it.
So if someone like that were to like code on the floor and we need to intubate them,
you should call us very quickly. And we're not saying that intubation is contraindicated. We had a patient who was in the CICU for a very long time, who is trached and vented and very complicated. It does happen, but we want to be involved in those cases.
Yeah.
Quickly.
I have two quick questions
You're fine.
along those lines. So would it be good practice for nursing that regardless of if we don't know their entire congenital history, but if we have a congenital patient, just to always put a filter on them?
So I would say that it comes to something I'm going to get to at the end of the talk. I would say that, the IV filters is something that we recommend for certain situations, not others. Bicuspid aortic valve disease is congenital heart disease. It's not something that strictly requires an IV filter, and I don't want the hospital coming after me saying like, "Oh man, you said that." I would say that with a certain level of complexity, like I would say that probably the best policy is to have a discussion with us. I don't think that I can say sort of a blanket rule. I think it's a reasonable consideration and something that should be at the front of your mind, and maybe as you create checklists about what to do and how to move forward with a particular patient, you should say, is this somebody I should be thinking about an IV filter? Ask your cardiology fellow, ask us. But it would make the IV filter guy very happy, and I don't know that like I can really. I don't want to kind of create a change in policy that would be a blanket that would be used often appropriately, but often not.
So as far as I know, I don't think that we have a policy for which patients require filters and which don't. So maybe we could like collaborate to create one, a list of what patients it would be appropriate for.
Yeah.
Because we like recently we had a patient who was in her 90s and didn't have a history of like a congenital history. But from a procedure that she had, they created like a large ASD. So we put a filter on her because we just assumed that we should. But it would be good to clarify because I think over the years we've never really
I've seen a lot of
who should and who shouldn't.
Yeah, no, I think it's actually a very interesting space, and as you kind of allude to, a lot of the proceduralists are making sort of intraatrial punctures or septal punctures for clips or TMVRs and definitely PVIs, and I've seen a lot of things happen with those different types of things. But I do think it's definitely a space that's worth exploring. But I also don't want to forget that I have a thing at the end that I want to pitch, and sort of this may go to that.
Okay.
What's your other question?
I'll save that for the end.
Okay. So ACHD, challenging cases, anatomically, physiologically, a lot to comprehend, but they're coming. The 2.4 million estimate is like from 2010. It's 2022. There's a lot more of them. We use a lot more help. Not that I want to recruit anybody away from the CISU. That's not why I'm here. But they are young patients. They want to be productive. They want to do things like get pregnant and start families and go to college and live their lives as best as they can. And they're really rewarding stories that we see. And really, one of the great challenges of our field is trying to figure out how to use the best stuff that we do on the adult side and use it for these patients for non-traditional fixes, non-traditional thought processes. We don't have any 10,000 person trials for medications to use in heart failure for congenital heart disease. We have to do a lot of like what's intuitive based on their physiology. And the nurses in this field are fantastic. I think Rob is a great example in that a lot of the nurses who devoted their time to this know more than a lot of doctors. And so I really think it's like a place where people shine. And so this is the proposal that I was going to make, and I'm open for discussion about it. I'd say, the majority of the pictures, not the ones of like the movie, but the majority of pictures that I used were actually from this one single website. And it's pretty simple to remember, and you guys can distribute these slides as much as you want. Congenitalheartdisease.ch. So it's international in some way, but it's not proprietary. And I know full well that I have friends who are interventional cardiologists in this space, and they use these for diagrams and that type of thing. And so maybe a reasonable policy to employ in the ICU would be to make a best guess. Go to this website, print it out, put it on the patient room, and we can kind of correct it, draw on it, see how it works. The cardiology fellow can. We're happy to come by, do it, make the most of it. I think that could be a direction forward for sort of communication for us and for understanding, because every case is a little different. There's never, there's no blanket rule in my world. I don't have them typically. So like, I think, endorsing or embracing every patient's individuality is a big piece. And so maybe this can be an initial canvas by which we have like a conversation. There's also this book, which I have not read, but I found out about as I was generating this talk, and it's probably a really great book. It's called The Guide for Advanced Nursing of the Adult with Congenital Heart Disease. And I researched the nurses. They were actually all very credible, reasonable nurses to provide counseling in this space. So if you guys have time. And then I want to thank everybody that I work with here in the Philadelphia Adult Congenital Heart Center, Dr. Kim Partington, Rockdashell, Dr. Vi Kuhn, Linda and Kathleen, who are also great resources for you guys to reach out to if you see them, know them. And then Rob, Christian, Yadira, Madison, Tanisha, Khadijah, James, actually, James has just left us, so I need to update this slide. But Dewana, I also want to thank you. And I think that's it. Oh, questions. If anybody has questions.
Do you have APPs in your practice?
Yeah, so Linda and Kathy. Yeah, so we have two. And we're, I don't know, I mean, we, Christian and Madison, our new to our group, they work mostly in our outpatient structure. Yeah, no, I mean, we have a lot of patients. A lot of my job is being on the inpatient side of these types of situations. So our inpatient presence, though, the APPs don't come over here as much anymore. They used to.
Appreciate you coming and giving this talk.
Yeah.
Really informative.
Any questions from out there in the ether? All right.
Okay. Thank you.
Thank you.
I had one more question.
Sure. Yeah.
Just out of curiosity, I know like when we have patients here that are listed for transplant that are congenital, that your team will see them intermittently throughout their stay.
Mm-hmm.
Is anyone from your team in the OR for their transplant?
So one name that is, it's actually my huge error in not including. So Stephanie Fuller is the surgical lead for the program. We also work with Constantine Mavroudis and Mohammed Nuri, and they are sort of our surgical presence. So every Tuesday, which was yesterday, we typically have 1 to 3 of our congenital surgeries that are done. They get admitted to 7, they go up to 9. And so the protocol there has been that Dr. Fuller, Dr. Mavroudis, or Dr. Nuri go to the OR and work with the transplant surgeons.
I have more questions.
That's cool. Oh yeah, I got nowhere else to be. Let's go. Do you guys have places?
I'm gonna step out, but you guys go.
I'm just curious, like collaterals, how does that even, like, are they born with those collaterals, or is that just kind of how they compensate over time that these like vessels actually?
So collaterals in my mind are a product of stress. Stress meaning that like there is typically a reason that is driving for them to exist based on an initial anatomy. Now there's a lot of thought there, and they're trying to delineate some of the causes. So in some of our single ventricle patients, there's thought to be this particular molecule that it's called hepatic factor. I'm not sure exactly what it is. I don't know that anybody knows exactly what it is. But there is potentially something that is in the milieu of hepatic venous drainage that prevents the development of collaterals in certain situations. There's also pressure phenomena. So collaterals is also like a word that's used pretty loosely. There's AV collaterals, there are VV collaterals. And some of the time what we see is that pressure sort of like in the coarctation patient, that blood's got to go somewhere. And so pressure builds, and so those intercostal arteries grow out, and that's why we see those collaterals develop. So a lot of the time I think it's the product of stress rather than, there are people who are born with inherent venous or arterial, like AV malformations, those types of things. Those can be things that people are potentially born with. So there's a lot of variability in the periphery, and it's something of great interest. But in my world, a lot of the time, I think it's the product of stress or of sort of biochemical milieu. That's kind of a non-specific answer. That's the one I'd give.
So fascinating. I have one other question and now it's escaping me.
I got time.
If it comes back to me, I'll email you.
Would you say there are like different buckets of folks by condition that you're seeing age up more? Like I know.
So, so really what I would say is that, so this surgery, the one that they invented, was sort of like a palliation.
Yeah.
It like got them through to like a phase where they could grow, because you have to think it's also like tiny little kids,
yeah.
the size of a strawberry, to the point where they can have more definitive surgery. So this was, you know, like the Wild West back then. And as that developed and more of the kids grew, we could, you know, kind of do, you know, second surgeries and kind of help them grow. But I would say to that question is like before there were probably certain populations that were self-selecting. And now I think more broadly, the populations are growing everywhere.
Just like across the board, across all
So, like,
congenital
People who
conditions.
have profoundly complex congenital heart disease are now surviving to adulthood, who have, like, there was actually a patient, he was in 65 on this floor, and he has,
Thank you so much.
yeah, like, no right ventricle, like, really at all. He has like a tiny little right ventricle and sort of what we call an SLL arrangement. And so both of his tricuspid valve and his mitral valve go into his left ventricle. So
Your attention, please. Anesthesia set to help mean Ramden 4 PACU.
all of his
Anesthesia set
inflow
to
goes
help
into his
mean
left ventricle.
Ramden 4 PACU.
And
Your
he
attention,
has,
please.
he does
Anesthesia
have two
set
great
to help
vessels. So he does have
mean
pulmonary
Ramden
artery,
4
he has the
PACU.
He was born in Ukraine. So in Ukraine, I don't know what the circumstances was. He had one surgery when he was 3. His SATs were in the 70s. That's how he grew up. But I think there was a stress that was building. And so they did sort of an initial palliation, which is different from what they did, but was able to bridge him to the point where he's now in his 30s. He fled from the situation that's in Ukraine, and now we had to like rearrange a lot of his medications. But I mean, he does have, that's definitely not a guy who would have been alive, 50 years ago without some of the thought to like protect this or do that and reroute this. And so really one of the interesting things is like, you meet a lot of people with a lot of different types of hearts who are pushing the limits of what is known for their own condition. So like the surgeries, I'll come back to that a little bit. So that surgery on the far right, we don't really do that anymore for that type of heart condition. But a lot of the patients that we see now have that surgery. And
Your attention, please. Anesthesia set to help mean
we
Ramden
are,
4 PACU. Anesthesia set to help mean Ramden 4 PACU. Your attention, please. Anesthesia set to help mean Ramden 4 PACU.
see the end stage consequences of that surgery. But it's interesting because we don't do that surgery anymore. So this is kind of like this lost generation of people in a way, but we want to take care of them. Last year, I think we transplanted one of them. I don't remember if we did more, but I mean, like, that's the type of thing we got to think about. And it's also going to be this sort of like little snapshot in time, because in 50 years, there probably not going to be people who had that type of heart condition on the far right who got the surgery that they got. And so that's why the job is changing, because the treatments are changing, the surgeries are changing.
My final question.
Yeah.
I'm gonna let you go. What's the best, I guess, imaging or procedure to identify this, like each individual's anatomy?
So that's a complex question. So a lot of the time our patients come with imaging that is done in their childhood, and something that it's just like a sort of inherent rule, really, is that babies are smaller than adults. And so they have a very easy time getting echo images, getting like, you can see almost everything in the chest, all the way back to the pulmonary veins. You can see peripheral structures. It's much, much easier. So a lot of the initial stuff that they do in the pediatric world is echo. They do MRIs for the complex stuff. CT scans are really not done as much, even though radiation has decreased with modalities. They just don't want to give kids radiation. As the people get older, there are certain types of congenital heart disease where you can, see things reasonably by echo. But really, cardiac MRI is growing in in our ability to kind of understand how flow is going, how it's getting routed, tissue characterization, that type of thing. So cardiac MRI is one of the growing spaces, and the downside of congenital MRI is that it takes a lot more time than a lot of our other types of MRIs. There's lots of protocoling, that type of idea. But it's different for different people.
Yeah,
Yeah.
thank you. This was really fascinating.
You recorded it, right?
Ryan said it automatically recorded. He was in here when we started, so I hope so.
All right. Well,
Good stay.
for those of you out there, let's see how many people are listening.
I went to get my glasses again.
Hey, all right, we got a couple.
We lost a few along the way.
All right. Oh, there's a chat. There's a chat somewhere. Okay. Well, thanks, everybody.
Thank you so much.
Yeah.
That was wonderful.
And you, I'm sorry, I haven't met you.
My name's Josh.
You're,
Nice to meet you. I'm a congenital fellow.
oh, okay.
Yeah. Sorry.
Because we haven't seen that many recently. We used to have a lot.